Dear listeners, we're back with another podcast, this time on women's health. I'm Sadiya Ayaz, a GP and trainer in South West London and RCGP board member for the South London faculty. To give us a whistle-stop tour of what you need to know about women's health as a GP trainee, or indeed a GP, I'm really pleased to be joined today by Dr Anne Connolly. Anne is a GP in Bradford. She's also RCGP champion for women's health and also primary care women's health forum chair. And she was also recently awarded an MBE for all the work that she has been doing in this area. And it's really nice to have you join us today for this podcast. Thank you so much for giving us your precious time. I know how very busy you are. Tell us a little bit more about how you developed this interest in women's health.
Well, thank you very much for asking me to join you on this conversation. That's a great question. I don't quite know why I've got such a passion for women's health, but I guess it's because there's so much need in primary care. And there's so much variety that women present with. Women's health needs go right across a life course, don't they? And women dip in and out at different times of their life with different problems. And it's the holistic reproductive life course approach in primary care that we take that's always given me so much interest.
And you also do a lot of work, I understand, with asylum seekers, homeless, refugees as well. You have a great passion for that. Is that something that you've also been doing for a long period of time? Is that something that you've recently taken on?
So I've always worked in inner city Bradford. I was in a large teaching practice for many years and did a lot of women's health work there. Always worked with deprived communities, always worked with the diverse mix of the population we have in inner city Bradford, and then about 5 years ago changed practice to take up a salaried post in the inclusion health practice, dealing with supporting women and men, just anyone who finds healthcare difficult to access.
So in today's podcast, we are going to be discussing some of the common women's health topics, scenarios that we come across in primary care, and we do see a lot of it, don't we? To begin with, the first topic that I wanted us to briefly touch on and get Anne's expertise on is menorrhagia. It's a common theme. We see a lot of it. How do we define it, Anne? When do we need to do something about patients who present with heavy periods? What primary care investigations are relevant before referral, in your view?
You're absolutely right. Heavy menstrual bleeding is a really common complaint that women present with. The NICE guidance is very clear about how to manage heavy menstrual bleeding, and definitely worth looking at. Heavy menstrual bleeding is what matters to that woman. So we often ask the question about clots and the amount of bleeding, the length of time, etc., etc. But really, if it matters to her, then it matters. And we can't judge whether we think it's heavy or not. And also, the impact on women is different at different times and in different jobs. So having heavy periods when you can get to the toilet is one thing. But if you're working in a job where you like teaching, or working in a factory or in a supermarket where you can't just get to the toilet as frequently, then there's not just the physical impact of heavy menstrual bleeding, but there's a social and a psychological impact as well, and just the fear that some women have of flooding is immeasurable. So if a woman says she's got heavy periods, then she's got heavy periods. Mm-hmm. The assessment for us is really about how much we need to investigate and whether we can just get on with managing. So it's important for us to get the history, like we do all the time, the holistic impact of that problem on her, and then try to do a risk assessment about whether we think that she is fit and healthy and has heavy periods, in which case management might just be something we can get on with straight away, or whether there are specific risk factors that she has herself or other findings in the history that we take that would imply that we should do more tests. Fundamentally, every woman who has heavy menstrual bleeding needs a full blood count. That's really important because the anemia comes on so gradually that many women find that they've got a very low hemoglobin and just feel tired and don't realise quite how low their hemoglobin has got. So the one test we need to do on everybody is a full blood count. We must also consider pregnancy, STI, whether somebody's taking hormones that might cause the heavy bleeding, irregular bleeding with any of the contraceptives is something we just need to make sure of. So I always take the history, make sure that the abnormal bleeding is just with the period and not intermenstrual bleeding, not postcoital bleeding, because that will take me down a different investigation pathway. So if the woman says the bleeding is every month, this is when it happens, then the risk assessment is, do I think she's got something either structurally or histologically that's causing this? In which case I need to think, do I need a scan? Do I need an endometrial assessment by hysteroscopy? But if not, if she's not got a high BMI, not diabetic, not had a lifelong problem with the heavy menstrual bleeding, not taken tamoxifen, that's bad for the endometrium, not got a history of polycystic ovary syndrome, so she's the majority of the women who we see, then let's just think about getting on with some treatment on that day rather than doing lots of unnecessary tests. If, however, when I'm asking the questions, she says, I think I've got a feel of fullness in the pelvis or frequency of urine or pain during sex or pressure type feeling, then we need to investigate, we need to examine and probably think about a scan. On the other hand, if she thinks that if we think, there might be something histological going on here, such as, she's got the risk factors for the endometrium, such as obesity, diabetes, estrogen-only HRT, tamoxifen, then actually that needs to go for a hysteroscopy rather than a scan. So you need to understand what the impact of the bleeding is supported with that, do a full blood count. Then if there's nothing concerning in the history, then just get on with treating there. Don't know if that clarifies it, but it's about understanding what causes heavy menstrual bleeding. Yeah. And then thinking, do I need to investigate? The majority we don't need to investigate. We just need to think about treating.
That's really helpful, and you've given such a clear overview of what we should be doing, and particularly I think the question is in terms of how we investigate. So moving on to management then, if we aren't particularly concerned about there being anything concerning in history, like you say, what are the gold standards for treating menorrhagia in primary care? How do we go about it? What should we be using as our first line treatment? What are our options, and how long should these treatments be continued for?
So the easiest and the best in the short term is tranexamic acid. There are very few reasons we shouldn't use tranexamic acid. But if you're going to use it, the tricks are to use a decent dose. So that's a gram QDS, and get it in as soon as she starts to bleed. Don't wait for the heavy days. Get bleeding under control. Use it for 3 or 4 days at a higher dose, then start to reduce the dose as she goes through. That's the simplest way, and that's certainly something we should be thinking about on that first time when we're thinking, do I need to do other investigations? Shall I wait for the full blood count? What other information would she like to go away and consider for a longer term treatment? But get something in, so while she's waiting, she doesn't have to suffer a few more periods, because that would be really helpful. NSAIDs, ibuprofen, don't need to think about any other NSAIDs really. NSAIDs are good at helping with pain, so you can use them alongside the tranexamic acid, but they're not so great at reducing the amount of bleeding. So first line, tranexamic acid. Second line, and certainly a longer term management, or you could try this, you can start this first line if this is what she wants. but usually she might want some more information. Then think about any of the hormonal methods. So if she is fit and healthy, normal BMI, not over the age of 35 and smoking, no migraine, you could use combined hormonal contraception, and she could use that back to back without having to have a break between the periods. And it's off licence, but it's something that the Faculty of Sexual and Reproductive Health recommend. The gold standard is the intrauterine system, so the 52 milligram intrauterine system. We've got a few. We've got Mirena, we've got Levocert, we've got Benelixir. Those are the gold standard. They are the best accepted. They've got the best outcomes. You've got to find where you're going to get one of those fitted, and you might have it in your GP surgery where it's all straightforward, but sometimes that's slightly more complex. But any progestogens will also help some women. So the progesterone-only pill, desogestrel pills, will give some women some benefit. Or you could use longer-term progestogens. I tend to use medoxyprogesterone acetate or Provera. 10 milligrams is the licensed dose, but you can use that 10 milligrams BD or 2 at night if 10 milligrams once a day isn't enough. Again, it's off license, but it's very, very safe. So you could use that in the longer term. If failed medical management, then you might need to think about doing the investigations that you haven't done to start with. Or if she has completed a family, then treatments such as endometrial ablation, surgery, to burn off the lining of the uterus is the easiest surgical option, because hysterectomy, really these days we don't need many hysterectomies because that's sort of such big surgery. So it's about non-hormonal treatment, hormonal treatment, low impact, low invasive surgery.
That's really helpful. Thank you so much for covering that in so much depth and giving us a really useful idea of how to manage that. So moving on to managing irregular periods, and that's also something we come across in primary care quite often. How do we address this, particularly in a woman who might be overweight? How important is weight reduction in symptom control in patients with PCOS, which is, as we know, a common cause for irregular periods? And what advice should we be giving women with PCOS who are trying to conceive? That's a lot of questions.
So polycystic ovary syndrome is very common. It's much more common than we recognise. So polycystic ovary syndrome, basically, just think insulin resistance. It's such the same sort of management in the longer term as it is with our pre-diabetics or our diabetics, because the fundamental problem for polycystic ovary syndrome is insulin resistance. So our insulin levels go up. The rest of the body is resistant. The ovaries sort of they don't become resistant. So the higher insulin batters the ovaries, and it stops the normal fluctuation that we expect in hormones. So your follicles, and then it makes the ovaries make lots of little cysts. It probably ought to become primary. It probably ought to be polyfollicular ovarian syndrome, because you get all these follicles stuck in the ovary. They get stuck around the outside. It's called ring of pearls effect on an ultrasound scan. But these follicles, they don't get bigger, they don't get smaller, they just get stuck at the same size. So the body then gets confused. So follicle stimulating hormone stays low because we don't need any more. We've got lots of follicles. Luteinizing hormone, which is the driver to try and get one of these follicles to ovulate, goes up. So you get an imbalance. You get high LH, you get low FSH, and you don't get the mid-cycle surge we need for ovulation. Each of these follicles makes lots of estrogen. So we get lots of circulating estrogen, which compounds the problems with longer-term risks. We then don't ovulate, so we don't get any progesterone. We only get our natural progesterone from having ovulated and having a corpus luteum. So we've got lots of estrogen, lots of LH, no progesterone, low FSH. So you don't get the monthly cycles that we need to be fertile. Usually in the UK, it's not always, you will see some thin women with polycystic ovary syndrome, but the majority of women we see, because of the insulin resistance, then start to put on weight. And just like we see with our pre-diabetes or our diabetic population, often overweight and the extra fat tissue again makes too much estrogen. So the problems in the longer term, the short term, that you'll know the features of having too much androgens. In the middle term, it's about fertility, and then in the long term, it's about the long-term consequences of insulin resistance and also the excess estrogen that we're making and having no protection of our endometrium. So women then start to have erratic bleeding and risk developing endometrial hyperplasia and endometrial cancer. Polycystic ovary syndrome is a long-term condition, and usually the thing that drives us up and down the spectrum of problems is obesity. That's usually the problem, and we will have the same messages to give, the same complicated discussions with every woman as you have with your diabetic women, which is about if you can lose weight, then your symptoms, your problems, your longer term consequences will reduce. But recognising that women with metabolic syndrome always find it harder to lose weight. So it's about support, but fundamentally it's about weight reduction for the majority of those women. And as they lose weight, the periods will start to become more frequent, the longer term risks will become less, and as women start to get more regular periods with weight loss, therefore the fertility problems also go down. So that was quite a long way round of talking about polycystic ovary syndrome, but it's just the same conversation you have with your diabetics day in, day out about the importance of weight loss.
Yeah, and what do you feel about prescribing metformin for patients with PCOS?
A great question, and one we're often asked. At the moment, in the UK, we have no licence for metformin for pre-diabetes. As soon as that woman, and we should be monitoring our women who are obese, and you know, because it's more common in the South Asian population, obesity is probably BMI of over 25 in our South Asian women, BMI of over 30 in Caucasian women. Probably should be monitoring HbA1cs every year or every couple of years to see when, because of the risk of flipping over into diabetes. And as soon as diabetes is confirmed, then metformin is your first treatment of choice. But because we don't have a licence in the UK for use of metformin for pre-diabetes, right now it's not absolutely recommended, but I think we're increasingly seeing women with polycystic ovary syndrome and particularly fertility issues being put on metformin by fertility experts. It works well with clomiphene, so PCOS women who go into fertility units who are given clomiphene to promote ovulation are often put on metformin at the same time because they work together.
Mm-hmm. What advice should we be giving women with PCOS who are trying to conceive?
Well, firstly, weight loss. Mm. You know, we know that outcomes of pregnancy are compromised. So the pregnancy itself and also the outcome to the child is more complex in women who have a higher BMI. So women who are get assisted treatment with fertility should not receive that if they have a BMI of over 30. And that is what NICE say, and that is what the NHS fertility units stick to. So early, we should be telling women the importance of weight loss. We shouldn't be referring women into the fertility units with unrealistic expectations when their BMI is higher than 30. So if I have someone with PCOS, firstly, I spend a long time talking about it being a long-term disease, long-term problem, just like long-term condition, just like we do with our asthmatics, just like we do with our diabetics. It's a long-term condition. Nobody can magic it away. It's complex, it's hard, but weight reduction is always going to be the best thing. And I get those messages in early. The patient.info has got some very good information about polycystic ovary syndrome on. Verity is the charity for supporting women with polycystic ovary syndrome. Mm-hmm. So Verity, Verity. So signpost people to good, reliable information is the key. Otherwise, Dr. Google is awful about polycystic ovary syndrome.
That's, again, really, really helpful advice. Subfertility is also, we've touched a bit on that in regards to PCOS, but it is something also that we come across quite frequently in primary care, and knowing how to investigate this and when to refer is also really important. And what defines subfertility, as a reminder for our listeners? When do we refer patients, and what baseline investigations are necessary before referral?
So again, subfertility, as you say, is very common. It's meant to affect about 1 in 7 couples in the UK. NICE fertility guidance is very useful, again, about going through the list of how to manage, and supports you in those discussions actually with patients, because you can go back to it to say, look, here's the guidance, this is what I should be following. It's about supporting the couples as well. Once people get onto that fertility bandwagon, if you want, they get very stressed, and that will always reduce fertility. So it's about being supportive. It's very much about couple-centred care. It is not him, it is not her, it is them together, and that's a really important message to be getting out there, because about 1/3 will be due to the man, 1/3 will be due to the woman, and about 1/3 will either be due to them as a couple or you'll never know. So it's about being supportive as a couple. Mm-hmm. It's about doing all the other things, like anything else that will reduce fertility. Obesity in the woman, obesity in the man, they are both reducing factors. Smoking cessation for both couples. It's about not over-exercising, not under-exercising. So it's about a normal BMI for women. So very thin women will sometimes stop having periods. Again, that's obviously not great. So it's about the holistic picture, which is what we always do in primary care. Now, if you know somebody has got a reason that could be subfertility, such as she's had long history of endometriosis with multiple episodes of surgery, or chronic PID, or some reason that they've got, there's likely to be a fertility problem, then you can send them through to the fertility unit quicker. Just one of the other points that often comes up, with couples who are in another relationship, we mustn't let people, well, I've already had children from my other relationship, she hasn't. That blame culture is really not useful in fertility and couple-centred management. So just because someone's had fertility, been fertile with someone else, it doesn't mean that they would always be fertile with that person. So both people must be dealt with, must be considered. Now, from the investigation point of view, doing a rubella titer is always good in the woman, because if she hasn't got a rubella immunity, you would want to consider, do you get her immunised before she gets pregnant? So that's one blood test to do. The other one, the most important one, is follicle stimulating hormone, because you're trying to measure her ovarian reserve. And if you're going to do for FSH levels for fertility, then do it on day 2 to 5 of her period. So try and get her when she's actually having a period. Don't get her anxious about the weekend, or it's Saturday and I've got to have it done here, but just in the first few days of the period are really important to do the FSH level, and that's the most important one for her. And then you refer the two into your local unit yourself. Now, if he's not a patient of yours, then you can do her referral. He does his sperm count, gets the result from his own GP, and it's his information, so he's entitled to do that. and then he brings it and you send it in with your referral to the local unit, so that when they're seen in the unit, they've got the information that they need together as a couple. And they're the basic tests to do. Obviously, if there are other tests, like she's having infrequent periods, you might think about thyroid function tests, you might think about prolactin. If she's from not Caucasian, you might need to think about thalassemia screen, you might need to think about sickle cell.
Menopause is a topic we can't not mention in a Women's Health podcast. There is much greater awareness now amongst women in regards to seeking help for menopausal symptoms. When should we consider HRT? For how long, and which type of HRT are often common questions that we do ask ourselves in busy primary care. And what are the risks and benefits that women should be made aware of in the 10-minute consult? Can you also remind us of when we should be checking FSH?
Great, a lot of questions there, but you're absolutely right. There's a lot of information we need, and as to whether we can do it in 10 minutes, is absolutely no. So it's about sharing some of the earlier information and then often bringing someone back for another conversation. Menopause, as you say, is a hot topic at the moment, and to be honest, I think there are some unrealistic expectations of the use of HRT. So like every single consultation we have in primary care, it's about understanding what her concerns are, how it's affecting her, and it's an individualised conversation. One size does not fit all for HRT, not in prescribing, but also in not what her needs are. So it's about listening, as we always do, signposting, so people can make their own informed choices. Average age of the menopause, and I'll do an average person first because that's the easiest one to do. So average age of the menopause is 51. So around that time, from 45 onwards, menopausal symptoms, hot flushes, night sweats, infrequent periods, and then there's a million other symptoms, aching, palpitations, mood problems, anxiety, stress, sleeplessness, etc., etc., etc. And then you have to put the picture together. Lots of women also get very stressed at this time of life because they're trying to balance everything, but that doesn't necessarily mean it's due to menopause. It's about the assessments that we do all the time. But from 45 and above, we just can manage the symptoms. We don't need to do follicle-stimulating hormones for the sake of diagnosing menopause, and NICE clearly tell us that in their guideline. Under the age of 45, it's different because we need to be clear of the diagnosis because the management is slightly different. But once you've got the woman there with the symptoms, it's about a risk assessment for whether HRT is the right thing for her or whether there are other support that we should be giving. If we're going to do HRT, if that's what she's wanting, then first there's a risk assessment. So the risk assessment, really, and there are very few reasons women can't take HRT. Undiagnosed breast lump, she'll need that confirming first. History of breast cancer, that is something you need to think that probably isn't me to be giving that information about HRT. That's either a menopause expert, gynae referral, discussion with the oncologist, but previous history of breast cancer doesn't say they can't have HRT, but that's not something we should be doing generally in primary care. Irregular periods, so infrequent periods are okay, but if she's got totally erratic bleeding, going back to the start of this podcast, if she's got totally erratic bleeding at the age of 45, you might also need to think, do I need to investigate that first, because endometrial cancer or endometrial hyperplasia are estrogen dependent, so that's another one of those risk factors that we need to be excluding. Recent cardiac events, and you talk about 6 months, so recent heart attack, stroke, again, you wouldn't start HRT straight away, but they are the sort of the main ones. After that, HRT, think about whether that would help. There are three types of HRT that we really have. If she is only complaining of vaginal dryness, because that's one of the common problems, very, very unreported, but if that was her only symptom, then vaginal estrogens, really useful, can be given to virtually everybody. And don't worry about the 1 year, 2 years that some people think, that is lifelong, if that's what she wants. But then if she's got systemic symptoms, we need to be thinking, has she got a uterus? Hasn't she got a uterus? If she doesn't have a uterus, so she's had a hysterectomy, then we can consider giving estrogen only, because that's actually what she needs. So no uterus, estrogen only for the majority. If she does have a uterus, and that is even if she is amenorrheic following endometrial ablation, so if she does have a uterus, then you've got to give her a combination of estrogen to help the symptoms, but you've got to give her some progestogen to protect the endometrium, because if you give estrogen only, it risks getting endometrial cancer. So combined HRT for someone with a uterus, estrogen only for a woman who doesn't have a uterus. So that's the fundamental decision that you have to make. The complexities of HRT then get into, do you use a patch, do you use a tablet, do you use every day? Those are sort of the more complexities about how you give the HRT. Basically, if a woman has, within the last year of her period, you want to give her a monthly bleed. If you gave her continuous combined HRT, then it could cause totally erratic bleeding. So we need to sort of protect her for a few years to try and regulate her periods while she's on the HRT. So you give her the sequential combined HRT or a cyclical HRT. What that involves is giving estrogen all month, and then for the latter 2 weeks giving her either a combined product or make up the estrogen and progestogen addition. If she's more than 1 year after her last period, then you can give her a no-bleed preparation or a continuous combined preparation, and that has estrogen and progesterone every single day. So you either give it as a combined preparation that you prescribe, or you make up that combination of estrogen every day and progestogen. The only other way of doing it is to use a Mirena, and it has to be Mirena because that's the only one that's licensed at the moment. So put a Mirena into the uterus, and that delivers the progestogen that women need. It's only licensed for 4 years, but all the experts say 5 years, so we leave it for 5 years. It gives contraception as well, and you have to remember HRT is not contraceptive otherwise. And then you give as much estrogen as she needs to control the symptoms, either by tablet or patch. So that's sort of HRT in a nutshell. Now, there's the Primary Care Women's Health Forum. We've got some great resources on there, written by experts. I'm not taking any glory for these. Brilliant resources on there for prescribing for primary care. So have a look if you want. And the best resource is something written by Imogen Shaw, who is a GP from Cambridge. So if you Google Imogen Shaw, then on the Primary Care Women's Health Forum, it's all free to access. You'll come up with her prescribing for primary care. And I have to say it's the best thing that I've ever seen written, simply to get your head round how to do that prescribing in the right way, and the things you need to give, the information that you need to give.
That's great, and I think that's so needed. I think always helpful to have some useful resources to hand to know what you should be doing and what to follow. Thank you so much for sharing that with us. Again, all that wisdom in regards to menopause. It is a topic that sometimes does present with complexity. And why do you think that is? I'd be interested to get your views on that.
So I've been around long enough to know the answer to this, and have experienced all of this. And what happened was we used to give a lot more HRT out. So 20 years ago, HRT was believed to be not just a prevention for osteoporosis, which it definitely is, but also increasingly thought to be protective for cardiovascular disease. So we were giving out a lot of HRT. Then there was a study called the WHI study, the Women's Health Initiative study, and it hit the press. Never seen anything hit the press quite like it. All the front pages, your GP's giving you HRT attacks. It was terribly, the media did really damage with it. And so women suddenly stopped their HRT Clinicians stopped prescribing it because they were nervous about it, and HRT sales went right down. Over many years now, we've had increasing evidence again to show that HRT really does help. It helps with symptom control, certainly gives osteoporosis prevention, and probably, if you give it at the time of the menopause, is good for heart disease. Not great if you give it later on, but at the time of the menopause, it protects women while they're taking it from, or gives some protection for the majority about heart disease. So we've started to see the evidence build up again. There's always been an overarching fear, though, about what it does to breast cancer. So people have been nervous to prescribe it again, and then every now and again we get another paper which says it's not great for the breast. So we've continued to have this conflicting evidence, and lots of women haven't presented this to us for HRT because they've been frightened about it, and lots of clinicians have felt it's too conflicting and confusing, and they don't know which of the latest bits of evidence to hang on to. And then just as things were picking up, a couple of years ago, we got another warning about breast cancer. So again, some people were saying, "Oh, it's not great." So therefore, they've been nervous again, just as confidence was building up. And all of the negative studies hit the press, and we get told about them. Whereas the positive studies, you've got to really dig to get hold of that information. Yeah. Now, the British Menopause Society have got some very useful overviews on their website. So anybody who does want to have a clearer understanding of where the arguments are about HRT or not, have a look at the British Menopause Society, because they've got some very useful statements. So the HRT and breast cancer chaos is the last warning we got is over-egged, really. It suggests that HRT is worse for breast cancer than it is. We've all got our own individual risk. Obesity is our biggest risk for breast cancer. Alcohol isn't great for breast cancer. Smoking isn't good for breast cancer risk, certainly family history. So there are other factors that play into that discussion. Most HRT is taken on for about 5 years. That's what most women will be thinking of, to get over that time of their symptoms, and certainly for 5 years, the breast cancer risk. And different products have different risks, but generally the breast cancer risk slightly goes up a bit in that time. But when you stop taking it, it starts to drop down again. So that was a very long way round of answering your question. But I think it's probably just trying to explain why it's been so confusing.
Yeah, no, I totally agree. I think you're absolutely right. There has been so much conflicting information along the way, certainly since I've also been a GP. I do find that things change quite frequently, don't they? And it's just trying to build up that confidence again and going by the reliable data and focusing on, a lot of the positives that you've discussed as well as obviously addressing the risks with it. Last but not least, Anne, I wanted you to share your thoughts a little bit on the current situation in primary care and what that means for women's health. We're seeing increased pressures and demands throughout the NHS on service provision, both in primary and secondary care. Do you feel that GPs are overall well equipped in managing women's health problems, including antenatal, postnatal care? And where do you think are the shortfalls, and what could we be doing better to ensure that patients are seen in an effective and timely manner, given the current situation and the circumstances that we're facing?
The challenges for time are phenomenal, aren't they? The work pressures are just stunning, and the demands post-COVID, plus all the austerity, and our workforce. I think it's the toughest time I've ever known. So getting it right for everybody is such a challenge. Each of the devolved nations have come out with a women's health strategy, ambition, plan. Yeah. So we are seeing women's health in a place that I've never seen it in. Women are demanding more. The politicians are promising more. There's no extra money, no extra training, and then nobody's been taking anything away from us. So it's about how we keep up with all of that at the same time as doing everything else that we are trying to do. Opportunities, certainly upskilling a multidisciplinary team. So using our nursing workforce more, using the skills of the multidisciplinary team. Pharmacy, we're going to see more pharmacist engagement with women's health. Where women are happy to go to as well as coming to us as doctors. They've been nervous about coming to us because it's sort of been so under-supported, really, under-recognised. And still many women, particularly from the women I see from some of the diverse cultures that I help support, women, it's really assumed that women's health problems are, what women have to put up with. So, we're coming out of that, thank goodness.
Yeah.
So multidisciplinary team working, I think there are opportunities at PCN level to deliver sort of system at scale, so support at scale. We've done it for years with diabetes. We're doing it with dermatology, other local services. And I think on a PCN footprint, we can start to get more of an intermediate care again. So deliver in primary care what we can deliver. Signpost to lots of online resources that are out there. Get your list of charities that you trust, that you can say, look, go away, have a look at this information, think about what your options are, then come back and we can have another discussion about what's right for you. So it sort of saves time in your consultation, but it also allows women to think about their own choices. A lot of women's health is also about self-care, about understanding, about supportive management. It's not all about medicines. So use those resources, but make a list of the ones that you trust so that you've got them there. We're not going to, this is the time for women's health. It's not going to go backwards. So we do need to be thinking about how we add that to our other workload, but think smarter, understand more basics. I have a very simple way of thinking about heavy menstrual bleeding, fertility. I've got those simple tools, which I think we probably haven't used quite so much because it's always seemed so big and so confusing, but it isn't really if you can just get your head around a menstrual cycle. Primary care, women's health forum, we've got lots of top tips on there. We've got lots of easy to use resources. So have a look at that because they're very useful. We're just completing an e-learning module for the RCGP, which should be launched very soon on menopause. There's a screencast with that. We've done one on heavy menstrual bleeding. We've done one on endometriosis. So they're really useful to, free to access. We've got the Women's Health Toolkit online. We've got the Women's Health Library on the RCGP website, which has got so many resources in there. There's lots and lots of great InnovAiT articles. There's lots out there, but the question is how you fit it in with everything else.
Last but not least, Anne, what are your top 3 tips for trainees starting in primary care when seeing patients coming in with women's health symptoms?
Back to basics. Think logically. Understand the menstrual cycle. Because if you've got your mind around that, and I know this is, you'll have done this endlessly at med school and through your training, but if you understand the menstrual cycle, you understand women's health, you understand the relevance of the blood test, you understand the relevance of the risk factors, and I can't say that enough. It is so important that. The second point, which NICE say in every single guidance that they talk to us about, it's about holistic care, it's about life course approach, it's about understanding the physical, psychological, social and sexual impact of women's health problems. So it's that support, it's that different things that affect different women at different times of their lives. It's the support we give all the time in primary care, because if you listen, if you care, which I know you do, that's why you're there, to just give that support, and that unravels so much of the pressures and the demands and the confusion that's out there for women. And then the third one, that's complex, because there's too many really.
Yeah.
But there are lots of good resources out there to help you in primary care. Faculty of Sexual and Reproductive Health, lots for contraception. British Menopause Society, lots for menopause. Primary Care Women's Health Forum. We do the bit in the middle, recognising the other experts, so lots of resources out there. Women's Health Library, lots of resources. So get your go-to places so that you don't have to spend too long trying to find the bits of information you need.
And you have covered so many useful bits of information for us on so many topics today. We've discussed menorrhagia, irregular periods, PCOS, subfertility, menopause, and much more. I think it's been really, really insightful. I've certainly learned so much from our discussion today, and I'm sure as have our listeners as well, and all the useful resources which we will also add into the link for this podcast for access for our listeners. Thank you again for all your time today and for sharing all this information with us. And we hope you will be able to come back for more of these podcasts and talk to us a bit more about the many different aspects of women's health.
Great. Well, thanks very much for asking me, and always happy to talk women's health, and all the best for everybody who's listening, especially if you're young to general practice. It's a great place to be, but it's not an easy place.